Hi, my name is Yasasvhinie Santharam, and today I'm presenting an interesting GI bleed case that we recently saw in our ICU. Just to get started with a little bit of background, duodenal polyps are a relatively rare clinical finding, only reported in about 0.3 to 4.6% of individuals referred for an EGD, and they tend to be an incidental finding. Prior case reports have stated that pedunculated polyps appear to bleed more often than sessile polyps. While the frequency of bleeding duodenal polyps post-resection has been well documented, the frequency of spontaneous bleeding in duodenal polyps is still relatively unknown. Another important point is that upper GI bleeding following the use of pressors and septic shock often occurs due to stress-related mucosal disease and bleeding from existing polyps secondary to shunting of blood through the use of pressors. Now, we present a case of an 85-year-old male who presented with a past medical history significant for pulmonary sarcoidosis, dementia, heart failure, asthma, esophageal thickening of an unknown cause, without any prior EGD or colonoscopy on record. He was hypotensive on initial presentation and tachycardic and tachypnic as well. Physical exam was otherwise unremarkable, and he didn't have any evidence of active bleeding at the time. So in the ED, he was given IV fluids and started on norepinephrine and vasopressin. And then subsequently, he was admitted to the ICU for acute hypoxic respiratory failure in the setting of septic shock secondary to community-acquired pneumonia requiring intubation. Once he clinically improved in terms of his respiratory status, he was downgraded to the hospitalist service for about 5 days until they noticed that he was having sudden onset melanotic bowel movements with accompanying hypotension. The patient was then readmitted to the ICU for hemorrhagic shock and acute blood loss anemia in the setting of a suspected upper GI bleed. He was transfused 2 units of red blood cells and given more IV fluids, seemingly back to hemodynamic stability until a sudden episode of coffee ground emesis into his non-rebreather mask led to emergent reintubation. An emergent EGD at the bedside was performed, showing a singular, actively bleeding 6 mm sessile duodenal polyp in the posterior wall of the first portion of the duodenum. Photos of the actively bleeding polyp can be seen in the EGD photos in figures 1 and 2. Epinephrine was immediately injected at the site, and 2 hemostatic clips were placed, as seen in figures 3 and 4. A few non-bleeding ulcerations were noted on the anterior wall of the duodenum as well. After GI intervention, the patient remained stable with no further bleeding and was downgraded to hospitalist service and subsequently discharged to a skilled nursing facility. So after this case, we conducted an extensive literature review, and it appears that spontaneous bleeding of a duodenal polyp resulting in significant upper GI bleeding following the use of pressors in septic shock is quite rare. This case really highlights the importance of including polyps in the differential for an upper GI bleed, especially in the setting of septic shock where vasopressors can cause mesenteric ischemia due to a reduction in the splanchnic blood flow, resulting in mucosal damage and then bleeding from existing polyps. Regarding the management of duodenal polyps, there is no current established method or guidelines. However, our case demonstrates that duodenal polyps, specifically those with a visible and actively bleeding vessel, may be amenable to therapeutic options used in the setting of ulcerations with actively bleeding vessels. Thank you.